started here. So today we have Marc Rothenberg, who's professor and director of Allergy-Molecular at Cincinnati Children's, and we'll be discussing Eosinophilic esophagitis, excuse me. So Marc, thanks for doing this.
Okay. Well, good morning, everyone. Wanted to just list my disclosures. If you have any questions during the seminar, feel free to interrupt. It's fine. It may make this a little less awkward because it's not so much fun giving these talks without looking at anyone. So I typically start the talk by going over some of the basis of type 2 immunity and the breakthroughs that have taken place over the years since I started my career, and we've certainly contributed to this paradigm, which is familiar to most, if not all of you. But I'll just review that we now understand that allergens are initially encountered by the innate immune system, particularly the epithelium, and the epithelium liberates pro-cytokines, pro-Atopy cytokines, particularly TSLP and IL-33. And we've recently described something I'll come back to, which is the recognition unit, the sensor for the allergen exposure, which we call the RIP IL-33, which is a complex of caspases called the Ripoptisone that then leads to intracellular maturation of IL-33 and then released by a special mechanism that liberates this very potent cytokine that then activates dendritic cells to polarize naive T cells, particularly so that they develop a type 2 phenotype. And part of the reason I start with this talk, especially to the clinical audience, is because each of these steps has been elucidated through basic research, but then a number of this has led to clinical intervention strategies. And part of the reason for that is because the cytokines that are liberated are amenable to blockade with antibodies. And this Th2 cell is very potent in eliciting reactions associated with allergy because it makes high levels of IL-4 that regulates IgE production. I won't be going into that very much today, but also because the same cell is pathogenic in eosinophil associated disease by making large amounts of IL-5 that directly activate eosinophils, but also IL-13 that track the eosinophils by an indirect mechanism because the IL-13 receptor is also expressed by the epithelium, and this leads to a rapid induction of eotaxins, which are eosinophil chemotactic factors that then track the eosinophils in conjunction and cooperativity with IL-5. There's also other ways in which this is controlled, particularly at the level of microRNA regulation. And this is just a diagram showing that one microRNA we identified involved in type 2 immunity a while ago is miR-21. And what it does is it targets the IL-12, which you can see here in different species, has a consensus predicted target site that in fact is functional for binding miR-21 that down regulates IL-12 and then shifts the type 2 polarization to become more exaggerated. So there's a number of steps that have been amenable to treatments, and we've been involved historically since I was a student in the characterization and role of IL-5 and then subsequently testing. And work started in basic science prior to my involvement in 1986 when IL-5 was described as an eosinophil stimulating factor in mice, also a B-cell activating factor. In 1989, when I was getting my PhD, we showed that IL-5 was involved in human eosinophilic diseases. And in the 1990s, my lab, along with others, were working on antibodies in mouse models of asthma and showing that both IL-5 neutralization as well as knockout in mice led to an attenuation of the mouse models of asthma. And this then propelled the pharmaceutical industry to develop humanized antibodies, which initially failed. It was a small phase 2 trial, but there was a strong loss of interest in this, and there was a question about the value of mouse models of allergic disease at that point. My lab at Cincinnati Children's, though, was working on this. We had an IND to study anti-IL-5 in humans. We pushed through the number of studies, and we came up with the hypothesis after proving certain theories in humans that we needed to target different patients with higher eosinophil levels. And in fact, that led to a resurgence of an interest in this pathway, and that there were certain patients that would be more likely to respond, which was at that point, somewhat, quote, innovative hypothesis, but really very obvious that patients weren't all the same, that there were different forms of asthma. And if you treated patients that had higher levels of eosinophils with an anti-eosinophil drug, they may benefit compared to the original phase 2 trial, which was done in general asthma. So indeed, as you probably all know and been using these drugs since the first approval in 2015, that anti-eosinophil therapy is very effective, particularly at for moderate to severe asthma patients with higher levels of eosinophils. And this is having a big impact on the disease. And today we have 2 different antibodies that are FDA approved that block IL-5 by neutralizing it, Nucala and Synquare. We have an antibody that targets the IL-5 receptor, not only blocks the binding of IL-5, but more importantly, is designed so that it mediates antibody-dependent cellular cytotoxicity, or benralizumab, known as Fasenra, and this eliminates eosinophils very effectively. There's also other antibodies that are not yet FDA approved, including lirentelimab, that targets another receptor on eosinophils called Siglec-8, and this also has been designed to mediate antibody-dependent cellular cytotoxicity. So this is very exciting, and indeed, the science is pushing forth a number of different ways to better treat patients. So I want to turn our attention now with that background information to eosinophilic esophagitis. This is a clinical audience, so I'll start off with a case. This is a 16-year-old man with a 2-year history of dysphagia, epigastric pain, not responsive to anti-GERD therapy, and he presents to the emergency room with a food impaction. As an infant, he suffered from moderate eczema. Since adolescence, he has suffered from asthma and has been a slow eater. If you're a keen clinical fellow and you take a history and you find out that he has no history of food anaphylaxis, however, his father has a history of an esophageal stricture that requires dilation. So there's a number of features in this clinical presentation which will become more obvious as we go on, but it's important to note that this is a young male. This disease does run in young people. It does, however, occur in pediatrics at any age. The patients often are very atopic. They don't have food anaphylaxis, and they often have a family history of esophagitis, actually, eosinophilic esophagitis when you probe. However, as much as we'd love to make the diagnosis as allergists and immunologists, the diagnosis is still 100% dependent upon a GI doctor working together with a gastroenterology specialist, it's a pathologist, who will then look at the biopsies that are obtained following endoscopy. The image on the left is a piece of chicken that's lodged in the esophagus. The esophagus is actually boggy in appearance. It's pale. You lost the normal vascular patterns, and there's often these linear furrows and other changes. But regardless of finding these endoscopic gross changes, you need to biopsy, and you need to take multiple biopsies and then stain, which is standard H&E. Staining eosinophils is very obvious. One can see that this picture on the right is very striking, but this isn't an extreme case. This is just a typical case of eosinophilic abscesses and marked accumulation of eosinophils in the esophagus. An organ is normally completely devoid of eosinophils. So what I'd like to do today is answer some questions. Is EoE a new disease? What are the indications for considering its diagnosis? What is its natural history? What is the evidence that EoE is immune-mediated and not a simple reflux-related disease? How can we understand inheritance, and importantly, the disease-specific manifestations such as the tissue specificity, which is a general question in the allergy and immunology field, is why does a patient suffer from the disease in one particular location, in this case, a rare disease that's part of the atopy, which is the esophagitis. And what is the therapy for this disease, particularly interested in mechanism-based approaches and using personalized medicine as appropriate. So when we first started looking at this, and I was in my lab, just set up my own research lab over at Cincinnati Children's, I was working on the asthma models as I showed in the first diagram. And a lot of that was in mice, and there was a lot of work on blood samples. But all of a sudden, this GI doctor comes to my office and he tells me about these patients that he had seen that year. And he said, I can get you some samples tomorrow. And I said, what, human samples in pediatrics? And he said, yeah, you don't have to work in mice anymore. So I started working on it, and that was 1999. So that was the first patient I'd seen. It was quite interesting. That was the first patients that we had seen at Cincinnati Children's that year. So I had an allergy fellow, Chuck DeBrose, and I said, Chuck, go to the Path Lab and pull out every slide in the archives that ever was labeled as reflux esophagitis. And your job is to count the eosinophils in the esophagus. And Chuck works now, unfortunately, in private practice in Dayton, but he's a very strong allergist, published a number of papers with me. And he counted eosinophils. And if they met the threshold that we were using at the time, which was greater than 24 eosinophils per parallel field, we called that retrospective EoE. And what we can see here is that there was a substantial number of cases of this REE in these cases that were previously called reflux. You can see a very dramatic increase in the number of cases. That's because endoscopy became a very common procedure, particularly in pediatrics during the preceding 2 decades. So what we've concluded from these studies was that EoE was present in nearly 30% of all prior biopsies originally diagnosed as reflux. So this was not a new disease, but it was just a recently recognized disease. Then I had another fellow, Richard Noel, and he took a look at the first 103 patients that we saw in the county surrounding our hospital, which I'm not sure what it's like in Seattle, but we're the only pediatric GI provider. We're also the only pathology service. So every case that was diagnosed in Cincinnati had to come through our hospital. And he pulled out all the records, and there was no electronic records at that time. And he looked at these 103 patients, and he found this here, which was very interesting, was that the presentation symptoms, the chief complaint, varied as a function of age. And one can see in little kids that the problem starts with feeding, then it becomes vomiting, then abdominal pain. And as you become an adolescent, finally you have these symptoms of dysphagia and food impaction, which is the predominant symptom in adults. And this disease is so common now that if you're an adult, particularly a white male, and this disease for some reason runs in white males, we have a 50% chance of having EoE if you have chronic dysphagia and food and not even food impacts, just chronic dysphagia. So these patients are very atopic. When we first started working on this, we would skin test every patient, like every food that we had available. And what we found was that they had the classic wheel and flare reaction to these foods. They had bona fide IgE, which we can measure through the skin test or through testing in the blood. But what was surprising was that these patients were consuming often large amounts of these foods that they had IgE against. So this was perplexing, but it indicated this was an atopic disease and not likely to be IgE mediated. We then conducted the first clinical controlled trial in the disease in 2006, testing a simple hypothesis was that swallowed steroids rather than inhaled steroids, just have the patient swallow it in a manner which would bathe the esophagus would be effective. And this was the original study where we had the patients swallow 880 micrograms of fluticasone. And we can see a number of things in this 12-week study, what was placebo-controlled, that the drug fluticasone does work compared to the placebo. 2, that there was different responses depending upon how we defined the placebo, but how we defined responsiveness, particularly affecting the placebo response. And 3 was that even though the drug worked, there was a substantial amount of patients that didn't respond to the topical steroids. And we subsequently showed in other studies that even a higher dose led to an increased response rate, but there was still a substantial number of patients, about 25%, that do not respond to the fluticasone or even now the budesonide. So one of the approaches to treating this disease is to eliminate the foods in the diet, as you probably know. And work done in an early point of this disease was with elemental diets, which were shown to be very effective. And the GI doctors don't like skin testing. Maybe you don't like them either. I particularly don't. So they developed something called the 6-food elimination diet, which is just eliminating the top 6 foods that normally are associated with food allergy. That's referred to down in this graph as SFED. And the allergists were more interested in running the skin tests to every possible food and then eliminating every positive wheel and flare reaction. And that's called a skin test directed diet. So this is a retrospective study. So it's got limitations compared to what we're doing now, which are prospective diet studies. But what you can see here is a couple of important messages. One is the diet does work. 2 is that the diet not only works, but it really causes a dramatic decrease in eosinophil levels down to almost the baseline, which is 0. Many patients achieve what we consider to be normal, which is 0 to 1. But we see the elemental diet is very effective. The 6 food elimination diet, as well as the skin test directed diet. But what was interesting and somewhat disappointing to the allergists was that the 6 food empiric diet was just as effective, if not more effective, than using the skin tests. So today, skin tests using skin tests for directing the diet has really gone out of favor, and it's not recommended. But an empirical avoidance of foods, particularly the 6 food, but also now sometimes just limiting 1 food, milk, could be considered the initial therapy for this disease. So this data really substantiates the effectiveness of diet therapy, but the diet based on skin testing does not have superiority compared with an empiric diet that eliminates the most common food allergens. Now, when patients respond to this food elimination, it's quite remarkable because on the left, we can see a very inflamed esophagus with a large amount of change in the epithelium remodeling taking place. And on the right, you see a completely normal esophagus. The esophagus is a squamous epithelium. This happens to be a somewhat deeper biopsy because we can see the basement membrane and the basal cells, but also the lamina propria extending into the epithelium through this papillae. And then you see the differentiation of this multi-layered epithelium, which is a lot thicker than the intestines in the stomach. And you can see a non-keratinized squamous epithelium that looks similar to this human skin, although it's not keratinized. What's interesting is that when you add the foods back, and this is a dynamic disease, so sometimes patients develop further sensitization, they have a relapse, which is very frustrating for the patients, but also the doctors. And we can do this in mice with exposure to allergens. So we know now that this disease is food antigen driven. I've shown you some of the data that glucocorticoids can be effective, and this is topical delivery. And I'll come back to this, but PPIs are very important in the management of this disease, and that this disease is associated with responsiveness to PPIs in certain fraction of the patients, and this might be also considered an early treatment regimen. One of the things we initially found when we characterized our first 103 patients was the association with allergy. We did see that some of the patients had the family history. It was about 7 to 10%, depending upon how you defined it. And it ran with a number of allergic diseases. One of the things we also calculated out was the point prevalence. This is a 10-year point prevalence, about 1 in 1,000 individuals. This is still holding up today. So the disease is rare. It occurs in about 1 in 10,000 individuals per year, and it happens in both pediatrics and adults. There's currently about 160,000 people diagnosed in the U.S., and it's considered to be still a rare disease of growing importance. Now, in terms of understanding the etiology, one of the first things that we wanted to do was assess the role of genetics. And even though this is a rare disease, we were able to accumulate 100 twins with this disease. This was a worldwide registry that we had set up. And one can see in the general population that there's about 1 in 2,000 people that have it. If you have a sibling with this disease, you have a huge increased risk, 50-fold increased risk. However, that's still only about 2.4% of the patients. That's important. So if you're seeing a patient with this disease and the parents want to know what about the other kids, there is an increased risk, but greater than 95% of the time, they're not going to have EoE. In terms of the twins, I'll draw your attention to the monozygotic twins. They indeed have a high concordance. However, it's not a Mendelian disease that would be 100%. There is a role for the environment, and I'll come back to that. But we were most struck by the dizygotic twins. Dizygotic twins, as you probably recall, have the same amount of DNA sharing as regular siblings, 50% of the genome. Yet they have a 10-fold increased risk of the disease compared to regular siblings. This strongly implicates early life exposures as interactions with the genetic elements driving the disease. And based on this data, we had developed evidence for this to substantiate the early life exposure. And this is a small case control analysis, about 150 patients compared to matching controls. And one can see here increased odds ratios if you have prenatal risk factors like maternal fever, pregnancy complications, intrapartum issues like C-section, postnatal exposure to antibiotics. Acid suppressants are a risk factor for the disease, and there's a lot of interesting data coming out about PPIs in the first year of life and how that predisposes to allergies in general, food allergy, and also EoE, and this is an ongoing area of research. We also see that if you have a pet in the house in the first year, this is a protective factor for the development of EoE, and that's also been seen in other allergic diseases. So this data strongly substantiated the role of early life exposures. We're particularly working in my lab on the role of the microbiome. And what we've shown in our research, which is summarized here, is that the esophagus is colonized with its own unique microbiome. This was new information because people had thought when I first started working on this that the microbiome in the esophagus was basically just swallowed oral flora, that the esophagus was mainly not colonized. However, we can show that it has its own unique microbiome dominated by Firmicutes, including Clostridium. The esophageal epithelium is regulated by the microbiome based on germ-free experiments, and the barrier function is enhanced based on reconstitution. And we can also, interestingly, reconstitute the esophageal microbiome with a fecal transplant. That's quite surprising to me because the ficus does not have the same constituents at baseline during the homeostasis, yet it does reconstitute a germ-free esophagus, indicating that it's the local microenvironment in the esophagus that's dictating the final composition of the commensal microflora. We can also show that an esophageal dysbiosis occurs when we treat mice with antibiotics, and the germ-free mice are predisposed to allergic reactions, including the esophagus, and have an elevated IgE, and this is summarized in this image over here on the top. In terms of working through the genetics, this was some early work that we did, looking at genome-wide association scans, which is, in this particular case, a meta-analysis of 3 different data sets, which are referenced on the bottom. One can see that there are susceptibility regions in the genome that are very highly associated with the disease. There's a couple of messages here. First, the #1 risk variant is at the TSLP locus on 5q22. And you'll recall that TSLP is an epithelial cell gene product that regulates the barrier function, that regulates type 2 immunity. The other risk factor is a novel gene that we had not been working on before. No one had actually been working on. There was no association with allergies or EoE, which is at 2p23, which is at the calpain 14 locus. And I'll come back to that in a couple of minutes. But importantly, this gene product is specific to the esophagus. There's no other tissue in the body that expresses substantial levels of this gene product. And we have evidence that this is causing the eosinophilic infiltration and specificity for the esophagus compared to TSLP, which is more of a pro-atopy gene. There's other regions in the genome, particularly MC LERC32, which has also been implicated in other allergic diseases. So since you're an allergy group, you're probably saying, well, hey, EoE is an allergic disease. How do we know that the genetic elements aren't being manifested because of the co-linked allergy? So what we did in this set of experiments, which was done by Lisa Martin and Nero Hershey in collaboration with my group, was to generate a custom SNP chip, which had a number of genes associated with allergies embedded in them, so that we can probe cohorts of patients that had EoE and use different control groups. And in the upper panel, we're looking at EoE versus non-atopic controls. The level of statistical significance is indicated by the dashed line. And one can see TSLP, IL-4, and a nearby neighbor to IL-4 called KIF3 alpha as being susceptibility regions and SNPs for EoE. Now, when we try to stress out the role of allergies, we can look at an atopic control group. Now we're looking at EoE versus atopic controls. And one can see in the bottom panel that we now lose the IL-4 locus. TSLP is sustained, calpain 14 emerges, ST2, which is IL-33 receptor, also emerges. So this data really substantiates that allergy genes are contributing, that there are specific genes as well associated with EoE that are actually contributing. And it's an interplay between both, which is not necessarily shown here, but there is epistasis between the IL-4 locus and the TSLP locus. This data also begins to draw evidence for the role of the IL-33 pathway, particularly ST2. And I'll just briefly summarize our recent findings is that the epithelium is particularly involved in sensing allergens, and that the rhopoptisome, which is a complex of various intracellular cysteine proteases in the caspase family, get activated upon diverse allergens, triggering a concanical pathway of rhopoptisome-mediated maturation of IL-33 from a precursor that's normally stored in the nucleus, bound to histone proteins, to a mature form that's biologically active and then secreted in complex with histones. This then binds to the ST2 receptor, which is expressed on eosinophils, mast cells, ILC2 cells, and also, interestingly, pathogenic effect of Th2 cells with both primes for proliferation as well as cytokine secretion. So there's a number of different ways in which this pathway and the genetic elements, particularly in ST2, are influencing EoE and other allergic diseases. Now, one of the early approaches to uncovering the pathogenesis disease was through genome-wide RNA sequencing. Actually, this was genome-wide transcript profiling before RNA sequencing was done. This was an old Affymetrix high-density oligonucleotide SNP chip. But importantly, we looked at normal individuals, patients with a chronic esophagitis that did not meet the threshold for eosinophils, which is shown in the bottom, for eosinophilic esophagitis, which was at that time 24 eosinophils per high parallel field. But what's most notable is the upper heat diagram. One can see that there's a dramatic change in the transcriptome with upregulated genes in red, downregulated genes in blue. And this then allowed us to define what we call the EoE transcriptome. Now, this was very interesting because the number one gene in the whole genome that was upregulated was eotaxin 3. I happened to be working on eotaxins, cloning eotaxins, and characterizing their activity during my postdoc. So this was very interesting that 10 years later, we took a genome-wide approach, and the number one gene that was identified brought me back to the pathway that we were interested in, which was eotaxin-mediated eosinophilia. I'm not going to have time today to go over the 500 genes in detail that are part of the EoE transcriptome, but I want to also draw your attention to two other findings. One is that the mast cells signature was very dominant in the EoE transcriptome. And I'll be coming back to this because even though this disease is called eosinophilic esophagitis, there's a dramatic mastocytosis occurring. And we think that the mast cells may be very important in the pathogenesis and the clinical symptomatology. We also saw that there was loss of expression of a family of genes at 1q21. And unlike these other genes that are upregulated, in this region of the genome, which is the epithelial differentiation complex, there was loss of genes, including the familiar gene filigrin. Filigrin mutations are enriched in EoE, but there's every patient has a loss of filigrin expression along with other genes that are part of this epithelial differentiation pathway. So this gave us great insight and is continuing to allow us to elucidate the pathogenesis and develop further ways to consider personalized medicine, but also therapeutic interventions and also monitoring disease status, which I'll come back to. Now, in terms of the clinical utility of this, a number of years ago, we translated the genome-wide analysis into a convenient molecular diagnostic for EoE, which we call the EoE Diagnostic Panel, or EDP. This involves taking a biopsy, and we can typically get up to 20 biopsies in the esophagus from one endoscopy. So this is, a safe procedure. We take one of the biopsies, we pluck it into an RNA extraction vessel. We then extract the RNA. We perform reverse transcription. We then use standard multiplex TACMAN-based PCR multiplex arrays. We generate TACMAN curves, CT curves, and develop both a cluster analysis as well as a multidimensionality reduction analysis, which allows us to develop a particular score for the disease, which allows a definitive molecular diagnostic. We also have embedded in this array, this EDP, a number of informative genes that tell us about mast cell levels, Th2 cells, fibrosis, and steroid exposure. And this is one of the ways in which we are currently probing the disease in clinical samples. This is work done by the Consortium of Eosinophilic Gastrointestinal Researchers, which is 16 centers across the US, unfortunately not in Seattle yet, but it allows us to look at these patients across these centers. In this case, we're looking at the EDP analysis in 300 patients. And we can see on the right side that even though they all express that classic EoE transcriptome, they fall into different categories, which we refer to as endotypes, endotype 1, 2, and 3. These have clinical associations. Endotype 1 is more benign. Endotype 2 is more inflammatory, and one can see gross changes on endoscopy associated with that. And then we have an endotype which is associated with more tissue remodeling, loss of filaggrin, and increased loss of a particular protein called T-span12, which I'll come back to, and this is associated with narrowing and fibrostenosis of the esophagus. The T-span12 turns out to be very interesting, and we recently reported this. This is the #1 gene in the genome that's directly related to the stricture, the degree of stenosis, and the level of T-span12 is therefore proportional to the diameter of the esophagus. Looking at also a secret cohort, we can determine that T-span12 is inversely related to esophageal diameter, and is the most correlated gene with the narrowing of the esophagus. We've shown in vivo and in vitro experiments that IL-13 shuts down transcription of T-span12 in endothelium. And when T-span12 is knocked out in endothelium, in human endothelium, we have a release of extracellular matrix components, including TGF-beta, that then targets fibroblasts to spit out profibrotic mediators and extracellular matrix deposition that allow for increased fibrosis and remodeling change in the tissue. We also have seen, and I'll come back to this, that if you block IL-13, both in vitro, but also in patients, and I'll show you the data on that, T-span12 is increased, indicating that IL-13 is involved in its downregulation, and that this is one of the ways in which drugs that block type 2 immunity may work by increasing T-span12, and that this therefore indicates that fibrostenosis, which is endotype 3, may benefit from drugs that block type 2 immunity. Now, I showed you a lot of data today about the bulk sequencing that we have on the biopsies. More recently, we've been now able to probe single cell analyses from these biopsies. And this is really a whole level of depth in terms of understanding the disease. And one can see here that in a single biopsy, which is only 1 to 2 millimeters in size, we can identify and sequence through sequencing each cell in there a number of different cell types. And I want to draw your attention to the epithelium that is undergoing a number of different changes from, and we've recently published an article on that, which is referenced below. But we also see endothelium, fibroblasts, mast cells, which I'll, going to come back to, a number of different myeloid cells and importantly, type 2 lymphocytes accumulating in a pathogenic effector T cells, which we've recently published on in the JCI, showing that the IL-13 is liberated from the pathogenic T cells in the tissue. One of the things that these molecular analyses allow us to do is to understand what pathways are dysregulated in the disease. And one of the things that we've been struck by is, and this was certainly unexpected, at least to me, was that some genes that we were normally interested in as immunologists were some of the main pathways involved in the esophagus. And this is under homeostatic conditions. This includes IL-1 family members, as well as an abundance of serine peptidase inhibitors, such as the serpins, the sphinx, and the cystatins. And this indicated to us that the esophagus is normally under homeostasis equipped with a number of anti-inflammatory pathways and innate immunity pathways that appear to be curtailing inflammation. And this led us to this model, which has been published in 2 recent articles, and I'll refer you to it, is that the normal epithelium in the esophagus expresses high levels of protease inhibitors. These protease inhibitors block the kallikreins and calpain-14, and then in the absence of the protease inhibitors, the proteases get unleashed. This leads to a degradation in junctional proteins, particularly in the desmosomes, but also claudins. They're part of the intercellular glue. And this then leads to a breach in the barrier through a loss of epithelial differentiation complexes, as well as permeability problems. And with the loss of the barrier function, we have an excessive production of pro-inflammatory cytokines, particularly in the IL-1 family members, as well as TSLP, that are produced locally in the esophagus. And this indicates that if we can block upstream proteases, by replenishing the loss of the protease inhibitors, we may be able to treat the disease. And we're currently enrolling patients in a proof of concept trial with anti-serine protease antibody, or alpha-1 antitrypsin, which is a broad spectrum anti-serine trypsin inhibitor, anti-serine protease inhibitor. So we will soon see if this theory holds, but it certainly holds in mice as well as in vitro. And this has led us to this pathway, which is showing that upstream is a loss of the antiproteases, particularly Sphinx-5 and 7. As you know, there are genetic forms of this, particularly loss of Sphinx-5 being associated with Netherton syndrome. And indeed, Netherton's patients have increased EoE. This leads to an liberation of proteases like the kallikreins that then degrade desmoglians, which are the proteins that hold the desmosome together. And this also is associated with loss of filigrin expression, which then leads to increased TSLP production, which then prompts the type 2 immune response. And we've shown that IL-13 is a very potent driver of calpain-14, which then is involved in the barrier function of the esophagus. So I want to draw your attention now to the mast cells. We think that this cell is particularly important in EoE. There's abundance of these cells that you normally don't see in H&E. You can see them readily with a single cell. And one can see that if you stain with antitryptase, that EoE patients have a higher level of mast cells. We also can see that they're degranulated by looking at extracellular antitryptase staining. And more recently, we've been able to show that we can divide based on gene profiling with signature genes for tryptase, as well as CPA3, which is both mast cell specific proteases. Patients with EoE have either high mast cell signatures or low mast cell signatures. And that the patients that have high mast cell signatures versus the low have increased pain in both pediatrics and adults. So we think that mast cells are involved in the disease and are very interesting in terms of their elicitation of specific symptoms, in this cohort, pain. Mast cells, we now understand more and more about what they may be doing in the esophagus through the single cell analysis, and this is looking at the genes that are expressed in these various cells that we're interested in. We normally think of type 2 cytokines being made by Th2 cells, and one can see here that IL-13 and IL-5 and other cytokines are made by T cells. But what's very striking is that the mast cells make just as much level on the mRNA, but also shown on the protein level of the cytokines like IL-13 and others that we think are driving this disease. And we can see receptors for a number of different key sensors, including leukotrienes, prostaglandins, the ST2, which is the IL-33 receptor, as well as the aryl hydrocarbon receptor. So mast cells are very poised to generate proteases, lipid mediators, cytokines, and other mediators in response to diverse sensing receptors in the esophagus. One of the things that we've seen is that mast cells exist in 4 different populations in the esophagus. And this is illustrated in this PCA plot on the left side. The different colors illustrate different genetic signatures for the mast cells. We can see this population here, which is a proliferating mast cell population. We can also see a population which we consider to be the homeostatic, a persistent population that exists only in patients with EoE, but persists during remission. Even though these patients have no eosinophils, they have the persistence of this abnormal mast cell population. And then we have this population here, which is the transient associated with the activation of the disease. This is quantification of these, showing the controls have mainly the resident, and then the patients with active or remission have variable levels, but particularly interested in the persistence of these mast cells in the disease. And it's important to note that these mast cells are locally proliferating in the disease. So we've identified 4 populations of mast cells based on single cell gene expression and divided them into disease-relevant populations designated as resident, persistent, transient, and proliferative mast cells. In terms of having the ability to genetically and transcriptionally profile patients, I just want to share with you information about PPIs, because this is an area of controversy, but also ambiguity, particularly with clinical people, but we've come out with strong recommendations based on this data and other data. If we look at patients with EoE and we compare them to those with GERD and normal, we can see that EoE is very different. So EoE is not associated with reflux disease, even though it's an esophagitis. However, people with PPI responsiveness who don't have acid reflux disease based on pH monitoring and manometry have an EoE signature that looks almost identical to EoE. And then when you treat these patients with PPIs, they normalize their transcriptome. So this data indicates that PPI responsive esophageal eosinophilia has a molecular overlap with EoE and provides supportive evidence that this form of the disease is a subset of EoE, and that PPIs are an effective treatment for EoE rather than a treatment for acid only or used in the diagnosis of the disease. So based on this, we now understand that PPIs are a therapy for EoE. And what we've been able to show recently published in the JACI is that the PPIs are a ligand for the aryl hydrocarbon receptor. In addition to the proton pump, PPIs are ligands for AHR, which is expressed by a number of cells in the esophagus, and this regulates genes that are related to IL-13, as well as proliferation events in the epithelium of the esophageal epithelium. And I'll refer you to this paper for more detail. So this has led to the consensus for the diagnosis of EoE, that if patients present with clinical symptoms, they should undergo a biopsy. If they're found to have greater or equal to 15 eosinophils per high power field, and they're ruled out for other non-EoE disorders, they have EoE. Then the PPIs are therapy, diet is a therapy, and topical corticoids should be considered as first-line therapy. Now, I want to focus my last part of the talk on the type 2 immune response, particularly related to IL-13. This set of experiments has to do with taking the biopsies, isolating epithelial cells from these biopsies, so therefore looking at primary esophageal epithelium, exposing it to IL-13 in vitro, and then doing a genome-wide expression profile analysis. And one can see here some very dramatic findings. One is that IL-13, within only 24 hours of exposure, is a very potent modulator of transcription. 2 is that this patterning is very conserved between patient samples. And 3, that when we line this up with the actual EoE signature that we get from patients, we see a dramatic overlap. And lo and behold, the number 1 gene that we get in vitro is eotaxin 3, which is the same that we see directly in the patients. So these data really substantiate that IL-13 may be imprinting the events that take place in the esophagus based on the molecular profiling. To test this in vivo, we generated IL-13 transgenic mice that were inducible with a system that regulated IL-13 exposure and production based on exposure to doxycycline, which you can see in the lower graph. This construct allows accumulation of IL-13 in both the esophagus and the lung, and it's dependent upon the exposure to the doxycycline. Now, the reason I'm showing you this is because the esophagus becomes EoE-like when the IL-13 transgene is turned on. One can see a normal esophagus in A. This is the epithelium. This is the lamina propria, and this is the muscular layer, which you normally don't see in the human biopsies. With the IL-13 exposure, you can see a thickening of the epithelium. You can see an infiltration of cells in this stained for eosinophils. You can see that these are mainly eosinophils, and a number of other changes that take place, including collagen deposition. So overexpression of IL-13 is sufficient to induce esophageal eosinophilia and tissue remodeling, including epithelial hyperplasia, epithelial cell thickening, fibrosis, and angiogenesis, all features that we see in the human disease. Now, this allowed us to map out the transcriptome that was modulated by IL-13 in humans by taking a look at the effect of an antibody that we exposed patients to in early work. Now, it turns out that slide was left out from this deck, but basically about 7 years ago, we looked at a drug that was called QAX576, and we gave it to patients, and it was an antibody against IL-13. It was a controlled trial. And what we found was that the eosinophil levels were indeed reduced by this drug. And when we reprobed them at the level of the transcriptome, there was reversibility of the transcriptome by the drug. This data shown in this slide is the networks that were modulated by the anti-IL-13 in humans. So I hope that you can follow this without that missing slide. But the bottom line is, and that what we've mapped out here in humans is that the IL-13 is involved in cardinal processes involved in type 2 responses, particularly in the esophagus. And certainly we now know that this is also operational in other tissues, but this was before we had the data in the other tissues. And this includes collagen remodeling, generation of chemokines, modulation of ion channels and barrier function, as well as the protease pathway that I talked about earlier. So in order to further test this hypothesis in humans, we've been working with the drug dupilumab, which you probably know blocks the shared receptor between IL-4 and IL-13. This is showing you the drug's targeting of the IL-4 receptor alpha, which is part of both the type 1 and type 2 receptor for IL-4. IL-13 binds to the type 2 receptor through the IL-13 receptor alpha-1, which is a specific chain receptor for IL-13, but the heterodimeric complex with the IL-4 receptor alpha leads to a high affinity IL-13 receptor. So patients were exposed to this drug, and this was early work that we did in a phase 2 trial. This was run by the company Regeneron. This is a small study with 47 subjects, including patients that were randomized to the placebo. But one can see here is the drug is very effective at reducing eosinophil levels, improving symptoms, as well as endoscopic findings. This led to a phase 3 trial, which has been completed about a year ago, and the paper is now in press, which showed that eosinophil levels are dramatically decreased with both weekly and biweekly dupilumab at 300 milligrams, either per week or every other week. This is looking at an FDA-established threshold of less than 6 eosinophils per high-power field, and one can see dramatic effects compared to the placebo in terms of lowering the eosinophil levels. We can also see dramatic improvements in a patient-reported outcome metrics called the Dysphagia Symptom Questionnaire, or DSQ. The drug works at reducing symptoms compared to placebo. But what's notable is that the drug only works when it's given every week. So unlike the histological findings that improve when the drug is given even every other week, the symptoms improved at every week dosing, not every 2 weeks. Histological changes and endoscopic changes were further characterized, and both doses of the drug, Q weekly or the Q2 weekly, improved the histological and endoscopic scoring of the disease compared to the placebo. Coming back to the transcriptome, one can take a look at the combined data from a number of parts of this phase 3 trial. This is a complicated slide, but I want to draw your attention to a couple of take-home messages, which is that there are 2 patterns of gene expression. One is the baseline, and the other one is the placebo treatments, and this is the baseline for the patients that got the weekly dosing. One can see here that following the drug in either part A or part B of this study, at both Q week or Q every other week, shown here, there is a very dramatic improvement in the transcriptome. And in fact, when we extend the drug to 52 weeks as opposed to part A and B, which was 24 weeks, we can see a continual improvement in all patients that got the drug, whether they got placebo initially or continuation of the dupilumab. So this data collectively shows that dupilumab is very effective at blocking type 2 immunity in EoE, and that this is very relevant in terms of improving the transcriptome as well as histological and clinical endpoints. This is a summary of the data, which is that IL-13 is driving many of these responses. The IL-13 is made by both effector pathogenic memory Th2 cells as well as mast cells. IL-4 is likely to be involved, but it seems to be less dominant based on data that I haven't necessarily shown you today. This then targets the epithelium to produce eotaxins, increases the calpain-14 production, as well as loss of filigrin, and this impairs the barrier. IL-13 also induces fibroblasts to become profibrotic, as well as the endothelium to develop angiogenesis, including loss of T-span 12. And dupilumab has, as I explained, a number of clinical benefits that associated with these histological and molecular pathogenic improvements outlined on this slide. And this then led to the recent approval of this first drug for EoE, which was just approved this year on Eosinophil Awareness Day. That's appointed day by Congress, happened to be the same day that the FDA became vocal about approving the drug, which is now available and transforming patients with eosinophilic esophagitis. Be happy to talk about the usage of this during the question and answer. Wanted to summarize a couple of things in the final slides. One is that we've recently now looked at all the patients that have gotten eosinophil depletion in humans. Very amazing ability to do this in humans rather than just mice, and therefore developing really what we call eosinophil knockout humans that are induced by drugs. And one of the things we've seen is that these patients do quite well, and that there doesn't seem to be any major effects of knocking out eosinophils that are adverse to the immune system. More data is certainly needed on this. We predict that this is a very important step forward, not just for helping patients, but dividing patients into those that are dependent upon eosinophils, like asthma, but also diseases that may be eosinophil independent, that are associated with eosinophilia, and that includes certain variants of eosinophilic esophagitis, even talked about today. Also want to highlight and propose to you that our data indicates that the esophagus isn't just a tube that transfers food, but is actually part of the innate immune system. It has its own unique microbiome. It's equipped with a very tight barrier composed of desmosomes. There's a large amount of antiproteases that are made homeostatically, and there are resident mast cells as well as large amounts of CD8 positive gamma interferon producing T cells, as well as the RIP-IL-33 sensor that's normally present in the esophagus. All of this is present probably to help us curtail inflammation and prevent the biophysical trauma associated with eating, as well as diverse antigen exposures from triggering type 2 immunity. Our data supports that EoE is not a defect in eosinophils, but rather a defect in the epithelium. And this data should be supported by the loss of the barrier function that we've seen, the fact that the susceptibility genes are encoded for by the epithelium, the imbalance between the proteases and antiproteases, as well as the ability of the topical steroids to induce disease remission because it's bathing the esophageal epithelium. And finally, because the esophageal transcriptome can be reproduced by simply exposing the epithelium to IL-13. Wanted to close particularly for the pediatric people amongst you that we've recently described we call very early onset EoE. And that even though EoE presents typically later in life, one of the most common forms of the disease is in the first 18 months of the disease. And we've shown that this is associated with an enrichment in variants in calpain 14, as well as the C-sections. So that if you have the genetics and the environmental exposures, it's likely to prompt for earlier exposure, earlier onset of the disease. However, as we recently reported in Jackie, these patients, which we refer to as very early onset EoE compared to late onset EoE, do not have a more difficult to treat EoE. So I hope that I've answered these questions. Is EoE a new disease? No, it's actually recently recognized. What are the indications for considering its diagnosis? Should be considered in patients with upper GI symptoms, diverse symptoms. It should be in the differential diagnosis, especially in atopic individuals. It is indeed immune mediated based on work that I've shown you today, but also mouse experiments. The natural history is persistence, evolution, particularly into the endotype 3. We can understand the disease manifestations by understanding the interaction between the gene and environment, particularly with early life exposures, and that calpain 14 is particularly important in terms of priming for the disease specificity in the esophagus, and that the therapy for EoE can be focused right now on PPIs, topical steroids, and diet, but also using targeted therapy based on anti-type 2 immunity with both anti-IL-13s that are emerging, but also IL-4 receptor blockers. I want to thank all the people that contributed. This is certainly a group effort involving GI doctors and allergists working together with pathologists, research coordinators, as well as others and geneticists. And I refer you to our website, especially EGID Express, which is linked below, because this is a site that allows us to share all of this data with you. It's freely available to the public in the public domain. And there's hundreds of people logging in from around the world to get the access to this data that can be useful to them. Here's the word of the day, so you can hopefully collect your CME credit. Thank you very much for your attention.